What can your physical therapist do for your low back pain? Let me explain. Hey guys, my name is Nick Helton and I am a physical therapist, also known as Dr. Nick DPT. I'm making a video series on low back pain and the physical therapy evaluation. This is going to be part 2 of the discussion of the objective measures of the evaluation. Now I made a part 1, please go check that out before watching this video because I've split the video up into 2 different parts due to the overall length of the video, so go check that out before you're watching this. With that said, let's just jump into the discussion on part 2 of the objective evaluation of low back pain. After that, I'm going to assess range of motion. Typically, I will go through range of motion grossly of the ankles, knees, hips, lumbar spine, all of those things to see what particular movements might provoke symptoms, if any. Now we're looking for a couple of things. One, we're looking for sort of their concordant sign or their pain, right? The symptom that they are seeking your services to try to change. That's kind of the concordant sign. Or even looking for an asterisk sign, which is a specific movement that they're describing that can reproduce their pain. So within those two things, those two kind of general silos, what individual movements reproduce a similar familiar feeling to what I just described in those two individual silos. So very simply, for the lumbar spine, I would first assess flexion, which is essentially just bending forward, trying to touch your toes. Extension, which is the reversal of the curvature, arching your spine backwards. Side bending, which is reaching your hand down to the side of your knee on either side. And then rotation, which can be seated, it can be standing. You can incorporate the hips, the just thoracic spine, or the entire spine, and you can look at that grossly or again more specifically. In general, I tend to assess these in standing unless balance or other sort of issues might prevent the patient from performing those in a standing position. If they are completely pain-free, no issues whatsoever in going to those end ranges of motion, I will typically add an overpressure to all of those, again, to see if we can provoke symptoms in that particular position. And again, the reason I'm doing that is to look for sensitivities to certain positions. So for example, if someone had some referred pain, say into the back of their thigh, and I was having them bend forward and that was sort of worsening those symptoms, however extension with a bit of overpressure was decreasing those symptoms or centralizing those symptoms, that would be something that I would include in my treatment model. So if we can find a way to decrease those symptoms with a general easy range of motion, that is what we're going to hammer on in terms of the home exercise program or self-care routine or whatever you'd like to call it. And the reason we're trying to be really specific with that is if we know that that person has a sensitivity to flexion, maybe one of the things we're going to consider is temporarily modifying flexion-based activities, which could be bending over frequently, it could be sitting position, and again, we're modifying those more so for the consideration of symptoms and less because we're saying that it's causative or sitting is some terrible thing for you and it's wrecking your body. There's two really different ideas that you need to understand with that. One is that we're saying, can I decrease my symptoms in the short term, make myself feel a little better by maybe standing every 30 minutes versus sitting for 8 hours in my shift. That's really what I'm going after instead of blaming sitting or flexion for the cause or the driver of what's going on with your symptoms. I then run through a very similar screen for the hips, flexion, extension, ab and adduction, internal and external rotation with overpressures, again, looking for sort of similar issues or reproduction of symptoms, comparing left to right, seeing if there's some movements that we can improve. A really simple but important concept to take a look at is active versus passive motion. So if actively the person is only able to lift their arm to here and I can passively bring them up to there, they have the available range of motion. So in general, doing a lot of passive range of motion is probably not all that beneficial for that individual unless we believe that person really needs to gain more passive motion, right? So I think that that makes a lot of logical sense when people hear it. They're like, yeah, obviously I would do that. But in practice, that just doesn't happen, right? So if your flexibility is excellent, you have great range of motion, in general, it's sort of a waste of time to really hammer on your flexibility, right? I would much rather have someone who lacks active range of motion do much more active activities, strengthening, things in that realm, than sit there and hammer on some passive stretching or foam rolling or whatever it is, because they already have that available range of motion. The same holds true with the spine. If you have the available range of motion, there's no passive limitation, but maybe there's an active limitation. That's where it's important to try to see if you can regain some of that through motor control, through strengthening, through those sort of things, as opposed to just passively hammering on the flexibility or increasing the tissue mobility or extensibility, because you're going to get a much better ROI on the strengthening. After that, I might quickly run through what's known as manual muscle testing. Now, the effectiveness or really clinical significance of manual muscle testing is, in my opinion, quite low. It's an isometric test held in an arbitrary position for an arbitrary amount of force. Perhaps there's an argument for using a handheld dynamometer, which is essentially a tool where you can gauge a little bit more of an objective measure of that individual muscle. But I don't think the standard, okay, hold here, don't let me move you, test provides all that much information. Now, that doesn't mean I might not do it, a quick screen here and there to quickly gather a few kind of objective measures. But in my opinion, the numbers that you gather for that are not of clinical significance in most cases, because it's sort of, again, an arbitrary range of motion, an arbitrary position. You can make the argument that you're standardizing to yourself, but there's a lot of external factors that play into this, and I just don't think you can gather that much significance from the actual testing. Again, I'm not saying I don't use these things, but just don't hang your hat on them. I think that that's the important take home. That said, I will probably be doing a full video on manual muscle tests, because I don't think I can adequately explain my thoughts in 1 to 2 sentences within this video. The next step is typically sensation and reflexes. So the reason I would test reflexes on an individual is if I suspect radiculopathy. So radiculopathy, I think, is probably a scary sounding word, but what it means is essentially we have some neurologic or nerve related symptoms. This could be loss of sensation, this could be sort of weakness in perhaps a myotome or a certain distribution of muscles, or this could be pain radiating down the leg, those sort of things. So there's sort of a spectrum, I guess you could consider, within lumbar radiculopathy. The reason that I would screen for radiculopathy is because if you have those kind of hard neural signs, as we call them, a loss of reflexes corresponding to a loss of sensation, corresponding to a perhaps certain muscle group being weak, there's probably a high likelihood that there is a degree of radiculopathy going on. Now, again, the reason I test that out is because those sort of things can clue you in if the person is having some sort of pain down their leg that is essentially referred probably from the spine. That doesn't mean I'm not going to treat the whole thing, but it's at least good to have that in the back of your head, and also for gauging if those symptoms are worsening. And just a quick note here, progressive neurologic symptoms typically warrant further referral to a specialist or a physician to rule out some serious red flags. The next thing I typically consider, especially in cases of suspected radiculopathy, is looking at sensation. So sensation is something as simple as light touch, or maybe something as a little bit more complicated as 2-point discrimination. So 2-point discrimination is essentially the distance between which someone could feel 2 different points. So for example, when people have a decrease or reduction in their overall level of sensation, they tend to struggle with identifying that there are 2 individual things touching them as opposed to 1. Now, I know that maybe seems a little bit complicated or convoluted, but the really simple way to do it is to have a little device that would essentially measure a certain distance between 2 points, and then you would ask the person if they can feel 1 or 2 points of pressure. Again, impaired 2-point discrimination is just another sort of piece of the puzzle that might kind of lead you into considerations for radiculopathy or loss of sensation. There's also light and dull sensation, so you can do sort of a blunt object or a bit more of a sharp object, and see if the person can discriminate between sharp and dull pressure. These again are all signs of changes in sensation, especially if you compare them contralaterally or to the opposite extremity. If there's great sensation on the left and not as good with the right, which correlates with their symptoms, again, that's another piece of the puzzle that helps you kind of put everything together in cases of radiculopathy. Just a quick bonus tip here, I will often try to gamify sensation with clients. So I will have them have a loved one, a family member, whatever, test out their 2-point discrimination, their sharp, dull sensation, those sort of things, to see if there are changes being made in the long term. Sometimes that just makes them more aware of these apparent lack of sensation issues, and oftentimes they tend to get better at it just from simply practicing the act. So I think that's a nice way to sort of gamify that and get that to be included within their home program or self-care routine. An important thing to note, during this entire process, I'm documenting everything that I find, either on my computer or somehow on my phone, just different ways to make sure that I've gone through my tests and measures, and then I've got some sort of system where I can kind of look back and refer to those tests and measures, both in the short term, in a couple weeks, or towards the end of the sessions, say 12 weeks down the road when the person is doing really well, we can kind of look back and see, and this provides us a nice way to gauge objective progress over time. Usually at the end of the list is manual therapy considerations. Now, if someone has a high level of pain, an inability to move, or exercise, I will sometimes employ some form of manual therapy technique. Now, I have to be honest, I don't typically utilize a lot of these techniques, and if I do, the discussion is, in my opinion, the most important, that we're using this for short-term gain, maybe to try to help the person move a little bit better with less pain. And again, it's not the most important part of the treatment. Realistically, it's sort of a band-aid that might provide some short-term relief for those who are experiencing moderate to high levels of pain that might be restricting their day-to-day movements. And the goal is over time to not have to use it at all. And realistically, you don't have to use it in any case, at least in my opinion. I just think it can be a nice adjunct treatment if you select the right individual. And going back to what I was discussing with asterisk signs, it's very important that you test your intervention pre and post intervention to see if you've made some reasonable changes. Now, you can never rule out the placebo effect, or the person kind of wanting to improve or having therapeutic alliance with the client, but at the very least you should be testing to see if what you're doing has any kind of meaningful effect on what the patient is coming in to see you for. As I previously mentioned, I may use some special tests. To be fully honest with you, I don't utilize a large variety of special tests because I don't believe that they are that special. I think perhaps the consideration is if you can cluster a numerous amount of tests, and if it will change your strategy or change your treatment, then I think it is probably an important consideration. But if it doesn't really impact or change your treatment strategy, I think it's a nuanced point that sort of has to be considered within the spectrum of usefulness, and it's going to vary between individuals and sort of each individual situation. Considerations for a special test are, does it have high sensitivity or high specificity? So if you consider the acronyms SPIN and SNOUT, so SPIN is specificity is very good at ruling in, SNOUT is sensitivity is good at ruling out. In a perfect world, a special test would have both really high sensitivity and really high specificity, but in the real world that does not tend to typically occur. I think if you have a test that has either high sensitivity or high specificity, that can be useful within the entire spectrum of the evaluation and considering the patient in front of you. But again, that's not something that I tend to really hang my hat on and focus on within the treatment. It's just a small piece of the puzzle. I'm going to do an entire video just discussing special tests in general, because I think, again, that's a video that probably warrants an entire discussion and not just a few sentences within what I'm talking about here today. I hope that gives you some, at least, ideas as to what to consider when you're having a physical therapy evaluation of your low back. Again, I want to stress this, that is not an entire comprehensive review of every possible thing that tends to occur within an evaluation. That's sort of just the highlights. I also wanted to mention, I typically will take the person's blood pressure just to get a very general screen of their overall health. I will try to establish rapport with the person. I will try to actively listen to that individual, and I will try to be present in the moment when discussing the person's individual goals, because in healthcare, oftentimes you go into an appointment and you're sort of talked over. You don't get a lot of opportunity to really discuss things that are going on with your healthcare provider. So I really try to make sure that the person in front of me has the ability to communicate those things with me effectively, because I think that's a huge portion of what needs to be done during the physical therapy evaluation. Now that said, that's the main points I wanted to discuss during the objective section of the evaluation. I'm also going to be doing a few more videos on the assessment and the plan portion of the physical therapy evaluation. If you're looking for an evaluation for yourself in person or digitally, feel free to reach out to me, or the links are down below in my profile. I do offer both in-person and remote sessions. Thank you so much for watching the videos. Please keep subscribed so you can see the content I'm going to be putting out in the future. I've got a few more videos that are going to be added to this particular series on the low back. And as always, I appreciate you for watching my videos.